paradigm. So for low risk or intermediate risk prostate cancer patients and they have a less than 10-year expected survival, then observation is appropriate. Um, for SSA life expectancy, add 50% if they're in the top quartile of health and subtract 50% if they're in the bottom quartile. Observation for less than 10-year life expectancy, you monitor every 6 months. You only treat for symptoms or a PSA greater than 100 with palliative ADT. Again, very low risk, no treatment unless they have a greater than 20-year life expectancy. And to reach that, you have to be at basically 62 or younger. Active surveillance requires a life expectancy of 10 years. Observation is recommended if they have less than 10-year life expectancy. If they've got a greater than 20-year life expectancy, still active surveillance is preferred. Alternatively, you can do external beam, brachytherapy, or radical prostatectomy with pelvic lymph node dissection if the probability of lymph node mets is greater than 2%. Active surveillance consists of PSA every 6 months, a DRE every year. You rebiopsy every 12 months. Pre AM MRI for baseline. For younger patients less than 62, consider an MRI with genomics like Decipher, Oncotype, Prolaris, or Promark. End active surveillance and start for progression on biopsy or patient preference. Triggers for biopsy are a PSA or DRE exam changes. Low risk, treat those with a greater than 10-year life expectancy. For a 10-year average life expectancy, the age is 77. Still, active surveillance is preferred, consisting of PSA every 6 months, DRE every 12 months, rebiopsy at 12 months, and another prostate MRI per baseline. Radiation is also an option. Radical prostatectomy, again, including pelvic lymph node dissection if the probability of lymph node mets is, or lymph node involvement, I should say, is greater than 2%. Consider moderate hypofractionation, 36.25 and 5, so prostate SBRT, LDR alone, high dose rate brachy alone, which is 27 and 2, or single fraction, high dose rate brachy 15 and 1. Active surveillance was originally based on the PIVOT study of VA men in poor health with only 10 years of follow-up, the new PROTECT trial with greater than 50% failing out of active surveillance at 10 years, and active surveillance with slightly increased chances of distant mets and clinical progression, but 10-year cause-specific survival is 99%. Radical prostatectomy obviously has more upfront incontinence, late GU incontinence, and erectile dysfunction. External beam has more late bloody stools, fecal incontinence, and loose stools. Low dose rate brachy has more LUTs in the first year and near equivalent erectile dysfunction. ADT only for downsizing the prostate prior to brachy. Intermediate risk, treat those with a greater than 10-year life expectancy. For an average 10-year life expectancy, the age is 77. Dose escalation in both favorable intermediate and unfavorable intermediate risk is associated with a 10 to 20 biochemical relapse-free survival benefit. Biochemical relapse-free survival may be improved with brachy boost by 20% with Ascend. However, typically lymph node coverage and external beam is not required for favorable intermediate risk disease, in which brachytherapy alone is okay. There appears to be a distant metastasis-free survival benefit in short-term ADT for greater than 50% course positive or Gleason 4+3 disease based on retrospective data. So this is why often you will add ADT for unfavorable intermediate risk. High risk, treat those with a greater than 5-year life expectancy. This is corresponding to an age of 87. In general, you do dose escalated external beam to 79.2 and long-term ADT, 18 to 28 months, plus or minus brachy, plus or minus docetaxel or abiraterone for very high risk. You may consider radical prostatectomy plus pelvic lymph node dissection for young patients if there's no fixation, as post-op RT and ADT are good salvage options. Counsel patients on worse quality of life after surgery if adjuvant therapy will likely be indicated. Node positive, ADT plus external beam plus brachytherapy boost plus or minus abiraterone, preferred definitive external beam with limited lymph node disease. Metastatic, ADT for 2 years or greater plus docetaxel plus prednisone or abiraterone prednisone. If it's castrate resistant, docetaxel or abiraterone or enzalutamide or radium-223. There's a suggestion of more fractures when abiraterone is used with radium-223 rather. The ERA-223 trial is placed on hold. Oligometastatic prostate management, M1A is distant lymph nodes, M1B is bony mets, M1C is another organ or site with or without bone disease. There's a benefit in treating the primary and mets if the patient has 1 to 5 mets, so you treat these definitively. You give intermittent ADT, darolutamide plus ADT for a PSA doubling time of less than 10 months, or if they're castrate resistant, consider docetaxel. 3-year overall survival is 77%, 3-year biochemical failure is 25%. First trial is StopCap M1. This is a meta-analysis of 2,000 patients in STAMPEDE and HORAD trials. RT to the prostate plus ADT versus ADT alone. The results: if the patient has less than 5 bone mets, radiation to the prostate improves overall survival. Radiation improves biochemical failure by about 10% at 3 years, and failure-free survival in all metastatic patients. For less than 5 bone mets, 3-year overall survival is improved by about 7%. Bottom line from StopCap is radiation to the prostate in patients with less than or equal to 5 bone mets improves overall survival. STAMPEDE, patients with known positive or metastatic disease. This is an adaptive trial that opens new arms and closes accrued ones with time. The high metastatic burden was visceral mets and or 4 or more bone mets with at least 1 outside the vertebra or pelvis. Low metastatic burden was anything less than that. ADT in all plus one of the following: prostate radiation, zoledronic acid, docetaxel, zoledronic plus docetaxel, celecoxib, abiraterone, metformin. Basically, what you need to know here: radiation was 55 and 20 or 36 and 6 weekly. Results is that radiation to the prostate in those with less than or equal to 3 bone mets plus or minus non-regional nodal mets improves 3-year overall survival by 10% and failure-free survival by 20%. So there's an overall survival and failure-free survival benefit to prostate radiation to those with low metastatic burden of non-regional lymph node mets. Sabre Comet looked at 5 or fewer oligomets. 93% of patients had 1 to 3 with controlled primary tumor. They either got SBRT plus palliative standard of care versus palliative standard of care alone. SBRT was 30 to 60 gray in 3 to 8 fractions, or a single 16 to 24 gray fraction for brain or spine. Results from this is SBRT to your oligomets improves progression-free survival and overall survival. Quite impressively, the median overall survival was 50 months versus 28 months. 5-year overall survival was 42% versus 18%. Histology did not impact the findings. Oriole, 54 patients with recurrent ADT-sensitive prostate cancer with less than or equal to 3 oligomets after radiation or radical prostatectomy of the prostate. They either got SBRT to the mets versus observation. 6 months progression-free survival was 19% versus 61%. 6-month PSA avid lesions, 19% versus 63%. SBRT resulted in T-cell clonal expansion. Overall survival was not an endpoint in this trial, and you should know that because of the paper you wrote. Bottom line is total metastatic ablation in oligometastatic prostate cancer with less than or equal to 3 oligomets, reduced progression, new lesions, and expanded T cells.